Breast cancer is one of the most common cancers among women in the United States, other than skin cancer. It is the second leading cause of cancer death in women after lung cancer.
The estimates for 2013 are about 240,000 newly diagnosed cases of invasive breast cancer, and then another 70,000 of the very early form of what we call in situ cancer. So altogether, a little over 300,000 women. It's estimated that a woman is diagnosed with breast cancer in this country once every 12 minutes.
Early detection is key to survival for breast cancer. When detected early, 98% of breast cancer patients survive the 5-year rate.
Early detection is important for two reasons. First of all, the earlier that we can detect that there's a cancer there, the smaller it is, the less likely it's had to spread elsewhere in the body. And that's really very, very important, which leads to the second reason, and that's in terms of treatment. So we not only want to detect them because the patients are going to do better when we find smaller lesions that haven't spread, they're going to survive better, but in the meantime, their treatment is going to be less aggressive as well.
The goal of screening exams for early breast cancer detection is to find cancers before they start to cause symptoms. Breast cancers that are found because they are causing symptoms tend to be larger and are more likely to have already spread beyond the breast. In contrast, breast cancers found during screening exams are more likely to be smaller and still confined to the breast.
Really, as of today, there is no other better test than screening mammography. The downside is that, as we know, screening mammography is not perfect. There is no test that's 100% perfect. So there are some cases where you just can't see the breast cancer, and the patient comes back for a 6-month follow-up or for a year follow-up, and then you see the cancer. You look back at those images that were done a year or so ago and you say, well, maybe there is something there.
Mammotome, the global leader in vacuum-assisted breast biopsy, has transformed the way that breast cancer is diagnosed.
Once the Mammotome was available, we now had a tool where we could percutaneously through the skin do a needle biopsy on those patients and determine what was abnormal on that mammogram. Then if it was a cancer, that patient could go on to the operating room, have her surgery, and have her treatment for her cancer. If it wasn't, as most of them turn out not to be, then we could just follow them up with imaging. And so it's totally changed the entire paradigm, the flow of patients, and how we practice in breast imaging.
At the time of Mammotome's release in 1995, 6 out of 10 women were going into the operating room to get diagnosis for abnormal breast lesions.
Technology was developed to be able to do minimally invasive biopsies. And since that time, we have shifted from open surgical biopsies to minimally invasive biopsies with ultrasound guidance, stereotactic guidance, and with MRI guidance to allow us to be able to change how we actually diagnose and treat breast cancer. We're able to use a minimally invasive procedure and allow patients to get a quick, definitive answer so that we can then plan their surgical procedures and give them all of their treatment options up front. So it's really revolutionized how we practice breast care.
Diagnoses of samples obtained with the Mammotome system are highly reliable. But unlike an open surgical biopsy, the Mammotome system allows you to have your biopsy in a procedure room or doctor's office rather than an operating room. An estimated 60% of all women will develop benign breast disease during their adult lives. These diseases often cause patients anxiety and, in some cases, physical symptoms. These symptoms can lead them to request removal of the benign breast abnormality. Surgical treatment of such abnormalities has been reported to account for about 50% of open surgical biopsies, resulting in considerable healthcare expenditures.
Vacuum-assisted biopsies have allowed us to take a device and place it into the breast one time and remove cores of tissue to either obtain a diagnosis, whether we find something is benign or malignant. We can use a vacuum-assisted device to remove what we call all image evidence, where we remove everything that we can see or everything that we can feel in a lesion. So it allows patients to have kind of the best of both worlds. They can remove the palpability of a lesion, and we can also do it under local anesthesia in the office to give them the opportunity to not have to go to the operating room and have a larger surgical scar anesthesia, and other potential risks or complications that come with going into a hospital.
Mammotome's latest technology, the Mammotome Revolve, brings greater efficiency to the breast biopsy procedure without compromising on the most important aspect of a breast biopsy: diagnostic accuracy.
Diagnostic accuracy is essential for us to make the appropriate diagnosis and to know how to treat the patient. So we have to have very accurate results.
So what the Mammotome does for us is it allows us to give an 8-gauge or a larger gauge core of tissue to the pathologist so that they can look at the specimen and tell us whether something's benign, malignant, or whether something has what we call atypical cells, which then require some intervention as well.
We added an onboard tissue collection system so that each sample is now automatically collected into this tissue collection system. The system then indexes so that all the samples are collected without the physician ever needing to actually touch the sample, but yet they can still see each sample collected. At the end of the procedure, physician simply removes all the samples at once, images them, and then can send them on to pathology for an accurate diagnosis.
In addition, Mammotome's minimally invasive procedure represents considerable healthcare savings.
What used to be a potentially 2 to 3 day process to have an open surgical biopsy procedure between pre-admission testing and coming to the hospital and possibly a day after anesthesia not being able to go to work, we've turned that into a procedure that takes between 15 and 30 minutes that can safely and easily be done in the doctor's office or a radiology facility.
Technology is evolving rapidly. Breast lesions can now be identified sooner and smaller, at a point when they represent a greater chance of successful treatment.
So think of it this way: there's the patient, there's the hospital, and there's the doctor. All three it has to work for. And that's not easy. Mammotome happens to do that. It's better for the patient, it's much better for the physician, and it's great for the hospitals.
For more information, visit www.mammotome.com or call 513-864-9000.